I didn't recommend locking anything down. I recommended to the president that we shut the country down. First of all, I didn't recommend locking anything down.
I didn't recommend locking anything down. I didn't recommend locking anything down.
I didn't recommend locking anything down. I recommended to the president that we shut the country down.
This is Broken Truth, and today I am super excited to bring in the lovely and talented Kevin McKernan, who's done an incredible amount of research into SV40, the monkey virus that was originally in the polio vaccines in the early 60s and late 50s. And Kevin's going to give us some important information on SV40 today. Welcome, Kevin.
Thank you, John. Appreciate you having me. Yes, the SV40 story is an old one, and there's probably other people you've interviewed that know a bit more about the polio history than me, but where I fell into this rabbit hole was with Pfizer vaccines. We found parts of that virus inside their vaccines that weren't disclosed to regulators. So that sent me down a bit of a rabbit hole looking into what those subcomponents do. We don't have the whole virus in the vaccine, so naturally all the fact checkers were running about saying this isn't the whole virus. Initially, they said there's none of this DNA there. Of course, that got refuted pretty quickly with Philip Buchholz's work. But then they started to claim that this isn't the whole virus. None of this matters. This is just a biotech toy. But it turns out the parts that are inside the Pfizer vaccine are actually very critical in terms of what we're looking at right now with this turbo cancer stuff. So for your audience, if you're not aware, there's a rise in cancer rates. This is evidenced in many different people's work. You're not seeing it evidenced on mainstream media, and you're seeing it probably refuted by many people on Twitter. But a few resources I point you to look at this are John Bodwin's work. He has been FOIAing the death records in Massachusetts, Missouri, Vermont, Connecticut. And when you do that, you can actually see the cause of death, and you get very detailed information on how they died, and find that information, because death records aren't protected with HIPAA. You can find that information that matches a anonymous patient in VAERS. VAERS doesn't have personal identifiable information. So by having death records, you can figure out how they died, what they were coded for, and then you can find a person who died on the same day in VAERS that have all the same age, demographics, what have you, and figure out their name. Now, the name's not really important, and John tries to keep all that private. It's just that you can see when there is someone coded for a COVID death that they had a vaccine very recently that's registered in VAERS. So it tells you that they were improperly tagging people as COVID when there was in fact a vaccine involved. So those death records show that there are certain cancers that are on the rise dramatically, particularly blood cancers. The other thing that we see that we can triangulate on this cancer thing is that Ed Dowd has put out work looking at the insurance data and insurance claims data, and he's also put out data looking at the drug sales for cancer drugs. Those are on the rise since the vaccine program. And then the third piece of evidence is a bit more tangential, but I still think very important. If you look at the acquisition activity of the pharmaceutical companies right now, they are on the spending spree buying up cancer companies. Pfizer spent $43 billion for Seagen. They also spent $2 billion or more in cash for Trillium. These are all, Trillium is a blood cancer company. So they're buying the companies to address the problem. And then of course you can go around and see a lot of the other physicians on Twitter speaking about this problem. I think Dr. Makis is one who's probably the most outspoken, who's been chasing down these turbo cancers. So there's a host of different data points that triangulate on cancer on the rise. It's happening in younger demographics than before. So this isn't a screening issue, because we don't screen kids for cancer. When kids start getting pancreatic cancer and colon cancer, this is not a screening issue due to the lockdowns. This is actually a new age demographic that's getting cancer when they shouldn't. So that, of course, has brought up a lot of questions. Like, what is driving this? Could it be the SV40 components in the Pfizer vaccine? So I dug into that a little bit, and I think you reacted to that post, but it was really a post from Dr. Makis that I was digging into, is because he's been having success using ivermectin and fenbendazole on these patients. So I started looking into if there's any connection between that and SV40. So some papers emerged. A lot of this is of course, literature dives using ChatGPT and other AI platforms. So it's by no means, hardened and proven science in the clinical sense, but there are anecdotes out there from physicians using these things with great success. So,
Kevin, should we sort of back up and go to the beginning and sort of explain to people what SV40 is, give them a top line or
yeah,
an overview?
Yeah, so SB40 is a simian virus that mistakenly ended up in the polio vaccines because the polio vaccines cultured that vaccine in monkey kidney cells. And when you culture a vaccine in kidney cells, you are exposed to all the other native viruses in those cells. And they didn't have tools back then to look for those. This is before they really knew about DNA. I mean, they knew about DNA, but it was, we're talking about in the 50s and 60s. They didn't have PCR. They didn't have DNA sequencing invented yet. Right, the ability to actually monitor all of the biological components inside of a kidney cell culture was just not there. So they got vaccines into people that they later found out were contaminated with SV40, the virus. And when that virus is given to animal models, it causes cancer. In fact, there was even a program to mutate this virus to turn it into a bioweapon. Jack Cruz is a good person to follow on that, but there's a lot of work using the LINAC down in Louisiana, which is a linear accelerator, to mutate simian virus. The reason it's called simian virus 40 is the 40th mutant of the virus that they were making. And there was some whole underground mission to, put this on a cigar and kill Castro with a bioweapon. So there's a crazy history with SV40. Now, when they try to find SV40 in the epidemiological literature, seeing if it is linked to increase in cancer, they of course find nothing. These are the typical epidemiological studies that are done to, create confusion. They study a huge population with tons of confounders and say, we can't find any signal here. But from a toxicologist standpoint, that's not how you measure carcinogens. You look to the animal models. If it causes cancer in an animal model, red stop, that's like a red dye number 3, get it the hell out. And they're ignoring that with SV40 because they don't want to admit what they did, which was they infected the world's population with, hundreds of millions of people with a polio vaccine that had a carcinogen in it. So that debate still rages today as to whether SV40 virus causes it. You look in populations, you can't really see the trends because these large epidemiological studies are done by very centralized science and institutions that probably have pharma ties. That's my general feel. If you take a decentralized approach and look at labs that can apply this to animal models, because that doesn't require some huge institution to study millions of people, it just requires a few people in a lab looking at animal models. They cause cancer. So now the question is, what part of this virus causes cancer? Because the whole virus isn't in the Pfizer vaccine, and a lot of things, a lot of literature points back to the tumor antigen. They call it the T antigen because no one likes to say tumor antigen too much, but it's the simian virus T antigen or tag that is known to be involved in the oncogenesis process. However, the more you dig in this rabbit hole, you'll find that that's not the entire story. That there are parts inside this virus's genome that are in the vaccine that have some peculiar functionality. In particular, it's the SV40 promoter and the enhancer, which are two pieces of sequence in there that overlap. Sometimes people use those terms interchangeably, but they're in fact, one's a little bit longer than the other, but they're mostly overlapping sequences. And David Dean has done the most work on those sequences to demonstrate that they are potent nuclear targeting sequences. And what that means is that proteins bind to that DNA and drag it through the nuclear envelope with an important gene, like an importation that's called important alpha and important beta. Those are like nuclear pores that help move proteins and DNA into the nucleus. So SV40 promoters that are in the vaccine do have that characteristic. And that's something that all the regulators are just refusing to look at. We keep pointing this out and they keep saying, well, the DNA that's in these vaccines is not functional. And that's not true at all. There's literature demonstrating they're one of the most potent sequences to get DNA into the nucleus. That is why they're used as gene therapy tools. So you find these in plasmids where people want to do gene therapy. And Pfizer's on record consulting with their gene therapy division to build these plasmids. Now, there's a paper from Thorne et al. That is titled The Journey of a Lifetime, which is kind of ironic. my paper, shows that, hey, we have a gene therapy division. We called them up, to advise of these plasmids. So we're not surprised that there's an SV40 promoter in there, because that is what people use for gene therapy. It drives DNA right to the nucleus. So that's one aspect of these DNA fragments that the regulators claim are harmless. The other aspect of it is from Draymond et al., who has published that sequence binds to a very important tumor suppressor gene known as P53. P53 is the guardian of your genome. This is what runs around and fixes DNA breaks in your genome, and you don't want that shut down. Now, we don't know what it's doing to that gene. To be fair, there's papers showing it binds to that gene and that protein once it's made. We don't know if it's inhibiting it, if it's accelerating it, but it's a red flag that it's binding to that gene, and that's a very critical gene to prevent oncogenesis. There's a third paper that's, I think, very important for people to understand this field, from Senegal et al., which only recently came out, but this was one that speaks to that sequence being a somatic hypermutability element. What that means is it drives mutations in other parts of the DNA. Particularly, this thing is involved in part of your immune system, in VDJ recombination. And in the paper, they speak to how it drives more mutations in the T antigen, but they make note that if you replace that T antigen sequence with something else, it will also mutate that. All right, so it has a process where it kind of recruits these enzymes inside your cell that are sort of your defense mechanism, known as ApoBec. These are enzymes that go and deaminate foreign DNA to try and make it non-functional. And this SV40 enhancer recruits those enzymes into the picture to start making some changes to see if it can get rid of this stuff. When a cell sees foreign DNA in the cytosol, it thinks it's a virus. And so it triggers an interferon response that tries to either mutate the DNA or get rid of it in some way. And these SV40 enhancers are involved in that process. And the final paper I'll mention for everyone to take a peek at is that everyone, when they hear about DNA going to the nucleus, the first thing they think about is genome integration, and that's going to cause cancer. But that may not be what's happening. That's one potential problem. The other problem that Kwon, Kwon, has published on is that when you chronically flood the cytosol with fragmented DNA, and the more fragmented it is, the worse this gets, you trigger an interferon response that can drive cancer. And this is what these shots are doing, is we're flooding the cytosol with fragmented DNA that are long enough in length to trigger this C-gas sting pathway that Kwon describes. So we've got a couple mechanisms of action here that could be a result of this SV40 promoter and enhancer DNA getting into the cell and mucking around with the cell circuitry of P53 and of the C-gas sting pathway, the interferon pathway, and then potentially getting into the nucleus and causing chaos in there, integrating into the genome. Now, we haven't proven the integration yet. That's something we've been working on in our lab and other labs. What we have shown is after you transfect these vaccines into cell lines, and then you grow those cell lines out for a period of time and rinse them frequently to get rid of the excess vaccine, the SV40 DNA is still there multiple wash cycles later. So that tells us the DNA in the vaccine is getting into cells, and we can wash off those cells and then detect it inside those cells after applying Pfizer vaccines. Ulrike Kammermer's group did a lot of this in Germany, and she even published some of these results. So surprisingly, got the stuff through peer review and demonstrated that this SV40 DNA is sticking around. It's not only in the vaccine, but it's getting into cells, and it's not going away in a rapid time frame. As I think she did that out for 30 days. So it's not disappearing in 48 hours like they promised. In fact, DNA is known to be a bit more resilient to degradation than the RNA. So we would expect it would stick around longer than the actual RNA.
Kevin, I just want to throw out there that some of what you're talking about for my audience, we've covered under the NIH Gate story.
Eric Fried. Yeah, he's busy with a shredder right now.
Yeah, the two most busy careers right now in DC are shredding and male prostitutes, I think. But that's just for the confirmation hearings. Anyway, that's a joke. That's not a real story. Maybe. Anyway, the story is that, briefly, Eric Freed is a National Cancer Institute researcher at Fort Detrick, Maryland, and he was the editor-in-chief of MDPI viruses. In, I think, the fall of 2021, a study came out stating that there was a link between the spike protein in both the virus and the vaccine that suppresses P53. And just like you were describing, and what they didn't connect it to at that time was SV40 components within the spike protein that were probably responsible for what you're finding too, right?
It could be both. I mean, that's the thing with cancer. It's usually, usually one insult doesn't cause it. You have to have a multiple hit hypothesis where there are multiple things driving this. So the fact that spike protein inhibits P53 as well can't be good. In fact, that work was adjudicated and vindicated by Wafik El-Diari at Brown Cancer Institute, and now he's under a massive smear campaign. There's people just trashing his papers on PubPeer, trolls that are running through, digging up papers from the 90s trying to cancel this guy's career, and it's a real shame. So the whole PubPeer retraction watch racket needs to be exposed because I've been getting notes from people that there's Pfizer people on their boards. And so this is basically an anonymous hit group that runs around and drags researchers' names through the mud to get their papers retracted, and they won't disclose their funding.
Right.
We've dug into it a little bit, and we can see funding from certain donors, but there's also some Pfizer influence on their boards. So it's a very it's basically an extension of the peer review system. If a paper happens to sneak through peer review, that's the backstop pharma uses to go and kill it. And it's not a very credible system. So I'd caution people looking at PubPeer as some legitimate mechanism for, I call it pub smear, because I've found that the arguments they use are oftentimes ridiculous. They're ad hominems. They're not well supported. And when I've tried to defend my own papers on pub smear, they delete my comments. The moderator step in.
Wow.
And there's even evidence of one particular person who's very frequently posting on there. Her posts go completely unmoderated. Like you can look at the timestamps of when they get submitted and when they get approved. And so we believe there's a few key individuals that we've identified that are the gatekeepers on PubPeer, and they direct it in a very political manner.
Yeah, it's funny. I investigate some of this too, and it's disappointing when people who exist solely to trash one side of debate then present themselves as impartial in terms of research scrutiny, and that's it's frustrating because that's what we want. We want people to question things. We want to have debate on science, but instead, what we have is, why are we picking apart 3-year-old studies that are just observational? Like, are they not allowed to make observations?
Right. Oh, they even killed a hypothesis paper from Sabine Hazam.
Yeah.
Like, what is this? It's a hypothesis. How can you retract? So we're not allowed to think about things?
But areas that I think need to be investigated are, some of the NIH's studies into SV40 in like the late 90s and early 2000s that were sort of designed to sugarcoat the polio infection of SV40.
That would be very interesting.
Now that we know, like 5 years ago, if you had said all these studies were crap, I would have said, it's maybe a couple, but not really. But now I'm like, yeah, pretty much everything is out there is garbage if it's gotten any attention.
Yeah.
And that's why I really don't get into the study debate anymore, because if you're in a trial and your witness testifies and your witness lies, everything that witness says from that point on is impeachable.
Yeah.
So why do we allow the FDA and the NIH and these institutions to lie to us and then turn around and claim, a logical fallacy of appeal to authority 5 minutes later? I mean, it's ridiculous.
Yeah, and that I think that also happens with a lot of studies. They won't be directly funded by Pfizer. They'll be funded by AID. And you're like, well, wait a minute, they have a $1.2 billion vaccine royalty moving into that organization.
Yeah,
this is not an unbiased, white lab coat that we're speaking to here. This is someone who has a motivation to keep the vaccine as the only solution to the code.
So to pivot now to the most recent research that you really got my attention with, one of the things, like when you understand that there is a smear campaign against this stuff, like, and it just happens. There was a smear campaign against hydroxychloroquine, which, shameless drop on my movie. If you want to see more about that, you can go watch
Yeah,
my movie Epidemic of Fraud at epidemicoffraud.com.
highly recommended. And thank you for that little expose you did on Flora. What is her name? Flora Teo, I think,
Yeah.
because she hit one of my papers as well. And,
Well, she made the mistake of trying to dox me.
uh,
So I had to live quote her doxing me and doxed her in reverse. It's a whole fun thing. But then another drug that was and is and continues to be smeared is ivermectin. And ivermectin was something that I sort of heard about. I didn't really get too involved in it. I took it a couple times just to see what would happen. Nothing happened. I didn't die. So I think that's a win.
did you steal it
Um,
from your horse?
Yeah, I did. I totally did. But so the interesting thing though was how vicious the ivermectin debate was. I mean, people, the FDA calling it a horse paste, to completely ignoring the fact that it's a human medication that is given away freely in Africa.
Yep, yep. Been on the list of essential medicines for years. It's
So the question remains, why was ivermectin such a target? And once you understand what they're targeting, you can sort of reverse engineer, if you are a little bit creative, the motivations behind the targeting. And that's why I thought what you told us this past week about ivermectin was interesting. So I don't want to spoil it. You spell
okay.
it out.
So first, this is not any of my brilliant discovery. I was just fumbling through ChatGPT one day when I was reading Dr. Mackis's work, realizing he's having a lot of success with ivermectin on these turbo cancers. Is there any connection between ivermectin and P53? Is there any connection between it and SV40? And it comes back with a handful of papers saying yes, absolutely. Ivermectin inhibits important alpha. If you remember the earlier conversation, not important, but import, like importing something to your country. Importin alpha is what drives that SV40 element, the enhancer and the promoter, into the nucleus. All right, so it blocks that trafficking. So and second to that, the fenben that he's using has an impact on P53. It increases P53 activity. All right, so a combination of those two. The other thing fenben does is it's a beta tubulin disruptor. So it basically slows down microtubule formation. So cancer cells that are dividing very quickly have to make microtubules, which are like these ropes that rip the DNA apart and help in cell division. You may have seen pictures of cell division with spindles, right? Those are microtubules that are making that happen. And so if you have a quickly dividing cell, you have to be able to make microtubules very quickly. And beta tubulin is a protein involved in that. And fenben actually inhibits that. So it slows the cell's ability to quickly divide and increases the P53 activity in the cell. So that's just what we need if this SV40 thing is in fact playing a role with P53, and if spike protein is in fact inhibiting P53. And then ivermectin just shuts down the ability to traffic that stuff into the nucleus. So it would shut off any avenue toward integration. So the combo of those two drugs makes total sense to me for fighting anything that might be negatively associated with the Pfizer vaccine.
Now, what concentrations of ivermectin would be required to achieve this result in the human body?
So that's a good question. And in fact, the post I put up had some community note come and hit it saying the concentrations you need you can never achieve. However, when they did that, they linked to a paper that was looking at inhaling ivermectin to fend off C19. Now that's a whole different issue. Dealing with coronavirus infections, ivermectin has many mechanisms of action. And so, you might need higher doses for it to inhibit the virus infecting you and taking off. However, the concentrations required to slow down this importation are unknown. I mean, this is all in vitro work. We don't have a good understanding of like how much you would need. For that, I would point to the physicians that are using this to probe them, like how much are you finding you need, and what's the effective dose for these things? Because it may in fact be very different to treat cancer than how much you might recommend, let's say, to fight off COVID. The COVID numbers are, if I remember this correctly, I think they're usually asking you to take like 20 to 50 milligrams. I think like once or twice a day, if I remember correctly. So it's not a terrible, it's not a very high dose. And I've taken those before too. Like last time I thought I had a cold coming on. Now that's my go-to is I just pop down a couple ivermectin. They're usually like 6 milligram or 3 milligram tablets, morning and night, and it's gone the next day.
And let's just clarify: we're not giving medical advice.
We're not doctors.
We're not telling you to take 50 milligrams a day or whatever. We're just hypothesizing and exercising freedom of speech discussion. So
Yeah. So I
for the
think,
legal.
yeah, the FLCC actually does have some guidance on their website in terms of how many, and they don't give you a total dose like I just did. They'll give you a dose per kilogram body weight. So if you're a 150-pound person, the dose is going to be lower. If you're someone that's 200 or 250, you got to escalate it accordingly. But the amount, the main point is the amount that seems to be efficacious for dealing with the SARS infection. It may not be the same number that's needed for fighting a turbo cancer, and that's something that it'd be good to get Dr. Mackis on here. He might be able to give you some of his experience, because I keep seeing him post day after day of different cases they run.
Yeah.
And it's endless. He just keeps finding more and more people that respond to this, and he's also under attack by the Canadian
Right.
what up there.
It's a difficult thing. Oncologists will have no information when you come to them about this. I've experienced a few cancer patients in my family in the past 2 or 3 years. Some of them had the vaccines. And when you discuss, fenbendazole or I've been told fenbendazole might be a little bit better. It's
Yep, I've heard that too. Yeah.
and then ivermectin, the doctors will just, kind of glaze over because they're instantly judging you.
Yeah.
And then secondarily, they have no information because they don't want to have any information, because a lot of the drugs that they prescribe in oncology are at $80,000 a month or higher.
Yes.
And oncology is an interesting field because I think, unlike most practice areas of focus, oncologists can actually bill you for the drugs they administer.
Yeah, the Stark law is distorted there, and so that's a bit of a conflict.
And anytime you incentivize something that is not in someone else's best interest, the customer, so to speak, in this case, which is a very sad way to call it, but what else is there? That negative things can happen because, we all assume that everyone has positive intentions. But if you tell someone that, hey, all you got to do is give this drug and you'll make $20,000 a month and you don't have to worry about payroll, or you can give this pill that's, really cheap, what's going to happen? I mean, the studies funding that research aren't going to exist because there's no money in it, right? So why would anyone fund that research? And frankly, that's what we have our agencies for, right? Is to fund research that wouldn't normally be funded by the market.
That's what they should be doing, but they're doing the exact opposite. They're only funding new therapies that can be patented, and highly leveraged by pharmaceutical industry. So, I mean, look at the COVID vaccine as a perfect example of this, right? Ivermectin could have supplanted that. They killed that and hydroxychloroquine. And the reason being is that there was a patent at the NIH that both Moderna and Pfizer and BioNTech had to license. So they have 1.2 billion in royalty rolling into the NIH on the vaccine. They never put out treatment guidelines that are outside of the vaccine. Like if you get sick, there's no answer from them on how to treat this. And sickness is when the vaccine failed. In many cases, sickness happened before the vaccine even came out. The bulk of the wave came before the vaccine was here. So the NIH never addressed how to actually treat this with off-label drugs, and that's a sign of the corruption that's going on down there, that hopefully the new administration will go in and clean house on.
I mean, you would hope, but the issue is that there's so much money in the government to continue this behavior. I mean, the NIH is a patent holder, right?
They are, yeah.
And that's I don't even understand how that conflict of interest could work, because why on earth are they doing that? So what do you think would be I mean, maybe that's the wrong question, but what we have is a suppression campaign against ivermectin that's come out since the earliest days of COVID. And it's a bizarre campaign. I don't understand why, but it involved the news media and everyone else. And the news media is, of course, funded heavily by pharmaceutical companies. And now you've got potential evidence that shows this drug can help prevent cancers caused by spike protein. What is the logical deduction here? Did they know that it was going to cause it and they wanted to make sure that we didn't have a solution?
Yeah, I mean that's harder to know. Just intentions are tougher to pin down unless you get emails that really show that it was deliberate. But they certainly aren't doing anything to address it now that it's overt and obvious, right?
Right.
I mean, even the FDA had a paper come out it was December 28th, where some high schoolers went into their labs and did some type of internship and found this contamination in vials. And they published it in like the Journal of High School Science, and of course, all the trolls are attacking it for being in a low rate journal. And you're like, no, the point here is that even high schoolers can find this fucking thing
From the mouths of children or babes.
in the FDA lab. It is using your reagents under your supervision, and now the FDA is like, we don't believe that paper exists. Or these aren't the drugs you're looking for.
You've got all this stuff going on, and once you realize, like, okay, the National Cancer Institute is not about curing cancer; it's something else.
Yeah,
Your National Institute of Health is about keeping you unhealthy. The Food and Drug Administration, I've spoken with former investigators who've told me that their job was more to protect the interests of the IP holders, uh, and the people that are supposed to be regulated by the FDA than it is actually to protect the people.
yeah,
The Centers for Disease Control seems to be designed to create more disease.
yeah.
I It's everything's upside down, and is it how do you feel about this Red 3 being banned after years of people begging for it?
Yeah, I think they see the new sheriffs coming to town and they're trying to get on board. Like, okay, we'll ban something that no one cares about.
What's the easiest thing we can do? Okay,
They can replace it with beets or some other
yeah,
natural dye.
but let's take 2 years to do it.
Yes, yeah, and that's not that or alcohol. These aren't the reasons for the sudden rise in cancer since the vaccines rolled out.
Right, and really it is sort of it speaks to a level of polypharmacy almost, that, yes, you've got SV40, but, SV40 in conjunction with asbestos exposure, dramatically increases your risks of mesothelioma, right?
Right.
That's even in Wikipedia. How did that make it through the Wikipedia censors? I don't know. That's another area where people are attacked is Wikipedia. There are people that control it that
Right.
don't allow positive information to be put out in certain topics. This is a real mess that we're in, and I'm grateful for researchers like you who do the homework and find these things because a lot of times that's what makes the difference. I think later on is drawing these correlations between areas that don't necessarily normally get associated.
This is happening in more places than people recognize. I mean, the reason my eyes turned onto it is that I've been watching this go on with cannabinoids. When my father went through cancer, similar experience. We sequenced his genome, sequenced his tumor. We got just intimate detail on what type of prostate cancer he had. It wasn't your typical androgen receptor mutation. He had something that would look more like a melanoma mutation. It was in BRAF K6. I think it was like 601E. So this is a documented mutation that's found mostly in melanoma. So they were marching him through, okay, we're going to treat this with hormone suppression therapy. And like, well, that's 90% of prostate cancer. That's the right move. But we have sequence information that shows it's not that. That this is a different tumor. It's probably not going to care about your putting him on Lupron. So they put him on Lupron, even though I bring him all these papers showing, look, you need to hit this with like an AKT inhibitor. And that's what all the literature says to deal with this type of mutation. And Lupron is not an AKT inhibitor. So what are we doing? You look at the actual side effects of Lupron and they match the progression of the disease. In other words, you're going to get less sleep, less appetite, more nausea, all the things that he's complaining about from the cancer. So once you're on their drug, when their drugs match the progression of the disease, how do you know if you're getting better or worse?
Right.
You don't. You're just on a treadmill to continue to the next thing that they have in line for you, which is going to be maybe a gamma knife surgery or some other experimental trial. So fortunately, we were working with physicians that were receptive to the fact that we weren't just woo-wooing this with weed, that, we're sequencing his genome. We found the mutation. It points to these cannabinoids, and we're going to give them to him. And by the way, the moment we give them to him, he starts eating and sleeping well, and he gets better. And so like, okay, we're not going to get away with that. That's fine. We can't advise on that. You can't take it here in our hospital. You got to, go outside or whatever. This isn't something you smoke. These are oils that people use. So his PSA dropped from 170 down to like 5 after we put him on these cannabinoids. And then he suddenly sprung to life, was able to walk around. We probably extended his life by 4 years. Um, During the course of that, we were sequencing his bloodstream to monitor whether the mutations were changing, because your cancer cells actually slough off dead DNA into circulation. And you can sequence that and keep an eye on, okay, what's going on with the tumor? Is it changing? And we did that with Foundation Medicine and a group at Johns Hopkins, and we did see a shift over time away from his BRAF mutation into a P53 mutation. And at that point, Dana-Farber freaked out. They're like, okay, P53 is involved. Okay, we got to hit this hard. We got to hit this fast. And that's where everything went downhill. Is they brought in much more toxic chemotherapies at that point. They tried to put him on a immunotherapy trial that blew up on him. And then eventually it went to like Gamma Knife. It got ugly really fast when they started throwing in a lot of these very toxic compounds. But I think the moral of that story is you do have to pay attention to the decentralized medicines out there that aren't controlled by the establishment, that aren't patented, that have known efficacy and low toxicity. I think the most important thing that the physicians are doing on this ivermectin and cannabinoid front is that these drugs are known to be non-toxic. Like that you can take enormous amounts of these things, and the LD50 versus the lethal dose 50 versus the effective dose 50 is a very, very wide margin. You can't say that about cisplatin. You can't say that about the majority of other drugs they want to put you on for cancer. They're usually very toxic, and you're threading a needle between killing the patient and killing the tumor. So I like to tell people, pay very close attention to these things that are banned or attacked by the establishment, because they're banned and attacked for a reason. That's a signal that they probably work.
Right. Yeah. What soft spot does the enemy think you have? That's the one you probably want to protect.
Yeah.
So, how do we, I would try to leave a positive message, but, how do we fix this? I mean, right now, I think any doctor in the United States is terrified to prescribe ivermectin.
Yeah.
And, oncologists are untrained in it. They have no idea of it, and they won't touch it. Or in most instances, you were very lucky, probably because you were a well-educated advocate.
Right. Yeah.
And that helps a lot with patients with cancer. But, can this, in theory, help people who maybe have a vaccine injury that could lead to cancer?
I mean, I can only learn from what they did in the cannabinoid space, which is they took this to the state level, because you can't get anything done federally. The more centralized something is, the more captured it's going to be. That just creates an attack surface for pharma to, if they can have one neck to bribe, that's what they want.
Yeah.
50 necks to bribe is harder. And you get down to the town level, it's even harder. So the cannabinoid space went over basically trying to legalize this state by state to get the feds out of it. And that has worked to get the medical access. And I don't know if something like that's needed for ivermectin and hydroxychloroquine, to be like, we need over-the-counter access to drugs that are known to have a certain safety profile. I mean, the safety profile of ivermectin, Tylenol is more dangerous. And Tylenol is over the counter. So,
Right.
you can totally destroy your liver with Tylenol. You're not going to do that with ivermectin. So there needs to be some type of, I think, movement from physicians to get the pharmacy benefit managers out of the picture, to get they have them to be able to prescribe like they used to be able to do off label, and to push for these very safe drugs to be over the counter, so that and maybe it has to be done state by state, so that they put in medical laws in each state that physicians have the right to use ivermectin and other drugs like this off label, so that there's a medical freedom side of this.
Yeah. It's a mess that we're in, but there's more hope I have more hope now than I did 3 years ago.
So many more people are woken up now.
What do you think about the stuff that they were talking about on Rogan with Mel Gibson?
So I only watched that 1 or 2 minute clip of it that was presented, and I mean, there is another case of someone who's got 3 friends that benefited from this. And that's I'd be hard pressed to find 3 of my friends that went through cancer that all had success on the same therapy, right?
Right.
And they're diverse. What he presented were different types of cancer, right? It wasn't all like, okay, I can understand if everyone with prostate cancer goes through Lupron and it works with X amount of success. But he was presenting, I think, colon cancer and pancreatic and something else. And when 3 different cancer types like that, and they're all responding well to the same treatment, that's very unusual. I think there's something there. Of course, the typical, I think Scott Adams was out there trashing it, saying, no way, prove it. But the reality is you're not going to find that proof in a peer reviewed publication.
Right.
It's very hard to design a study that would do that. No one will fund it, as you pointed out. And then the moment you try to get into a journal, it will get attacked because the journals are heavily moderated by their pharmaceutical advertisers. And then once it does get out, you're going to have the whole pub smear team jump on it and try and
Right.
kill it.
Yeah. Hopefully, we'll educate people enough to understand how captured our research is. Kevin, can you walk us briefly through your CV a little bit, just so people understand why you are an expert on this stuff?
So my background is actually in genomics. I worked on the Human Genome Project from 96 to 2000. I was a team leader for research and development there at the Whitehead Institute. My role there was building DNA purification tools to extract plasmids from E. coli. Very much identical problem that they're dealing with at Pfizer, which is extracting E. coli, plasmids out of E. coli to make the vaccine. I did that. I built robotic platforms that did over 10 million clones, and then all the tools needed to sequence those clones and feed the Human Genome Project Sanger sequencing data. After that, I spun that technology out in a company called Agincourt. We built that into one of probably the largest commercial genome center in the country at the time. We even got a grant from Francis Collins that was probably over $27 million. We were one of the 5 U.S. genome centers that were funded by NIH, the only commercial one. So Craig Venter was one, Eric Lander, Bob Waterston at WashU in St. Louis, and Baylor, Richard Gibson at Baylor was another. We had some of the most efficient DNA sequencing pipelines then. That company got acquired by Beckman Coulter because we built very useful magnetic particle systems for purifying DNA from viruses and from bacteria. That technology still in use today. It's has over 80% market share in the next-gen sequencing space. People use these magnetic beads for doing a technique known as SPRY. We spun, after that company got sold, we built another company. It was a skunk works project inside the company, and Beckman couldn't really value that. And so we spun it out as a 19-person company to prove the technology out for another year. And then Illumina and ABI got in a bidding war over that company. That company built a solid sequencer. This is a DNA sequencer that was 100,000 times faster than Sanger sequencing. It got absorbed by ABI. It went to market. We competed with Illumina for some time with the sequencer, but that's where I got a window into this cancer world. Is that sequencer was the most accurate sequencer ever built, and was predominantly getting put at cancer. Because in cancer, you're not sequencing a genome where every cell shares the same genome. Sometimes 20% of the cells have a mutated genome. And so you need to have a very accurate sequencer to sort out those really low frequency mutations that exist in a tumor biopsy. That's when I found friends of mine who were dealing with cancer. They were asking if they get their genome sequenced, their tumor sequenced. You compare the two, see if there's any druggable differences between them. And that's when I get a window to how the FDA operates and how they inhibit progress on all this front. So anyone who was trying to do this type of work, they would demand, like even 23andMe, when they initially got out and had those reports that showed you all your genetics, the FDA more or less shut them down. They let them put out reports on 1 or 2 medical conditions, and everything else they had to strip from their website because that direct-to-consumer genetics was pissing them off.
Yeah.
They were doing the same. They're doing that to the entire genomics field, and that was a bit disappointing. But so my background's mostly in tech dev on measuring DNA, sequencing DNA, and then clinical applications for it in sequencing.
So, what's coming next for you, Kevin?
Well, we're still humming along here at Medicinal Genomics. Our work currently is I got involved in the cannabis field when I saw it benefit friends and family, and decided that genome needed to be sequenced. It was never sequenced, and it was like 2011. That seemed insane. It had a pharmaceutical repertoire that was gold mine, and no one is working on it. So we set up a BV in Holland, sequenced the genomes over there, or at least extracted the DNA over there, and sent the DNA back and sequenced it in the States, and put the first cannabis genome live in 2011. And since then, we have been sequencing genomes for anyone in the field who's looking to do selective breeding. If you want to breed plants for particular cannabinoid profiles, we have tools that can help people do that. And then we also have tools that utilize PCR to monitor the pathogens that can be on the plant. There are some things that can grow in the plant that you don't want in your lungs. So aspergillus is the main pathogen of concern. There's also pathogens that destroy yield of the crop. So we look for those to try to keep people from having fusarium or hop latent viroid. These are things that destroy crop yield. So our focus now is mostly on bringing genomics to the cannabis field, so we can decentralize some of this medicine and get get all the safety tools that the FDA claims they have on the drugs that they approve but don't actually have.
Right.
We're going to have that on medicine you can grow in your backyard, and just do an end run around their whole centralized system there. So that's been our focus. We have a conference in June in Puerto Rico if anyone wants to go to. It's called CanMed, but that's a great conference to go to if you want to see how to decentralize medicine, because these are all physicians who have been living this war on generic drugs since the entire drug war began. And they've been doing it for probably 30 or 40 years in the cannabis space. And they have figured out how to get cannabis to epilepsy kids. Very hot topic, giving cannabis to a 10-year-old.
Right.
But physicians have figured this out by utilizing state law and by building networks of physicians that know how to get this done and not get their licenses yanked. And so it's a great conference that has a lot of physicians showing case studies, and then you have all the growers showing yield benefits and growth, and then all the safety testing folks that show how do we measure heavy metals, pesticides, cannabinoids, terpenes, and microbes that could possibly be contaminating these products. So if we can do something like that on ivermectin, hydroxychloroquine, that would be great. Not that you need to grow those things, but the physician anecdotes need to be shared somewhere at a conference so that doctors can figure out dosage and what works for which cancer. And so I invite all of them down to CanMed. It'd be a welcome community to share war notes, if you will.
Awesome. Well, everybody, the links to everything that Kevin mentioned in this interview will be below. And you can see them in the interview at brokentruth.tv and wherever else we post this. So, Kevin, any final thoughts?
No, thank you. If you want to follow me, I'm on Twitter. Medicinal Genomics is where I work. And CanMed is the conference we're holding in June. So those are 3 areas you can find me.
Excellent. Thank you so much, buddy. We'll talk to you soon.
All right. Thanks, John.
Mhm.